Focal Laser Ablation Therapy, or FLA. What is it? What is FLA? And how does it work for prostate cancer? Today's conversation is with Dr. Ara Karamanian, an expert in focal ablation or focal laser ablation therapy, yet another type of focal treatment for prostate cancer, and his approach with diagnosing prostate cancer using live in real-time MRI to target the prostate lesion in the prostate. How is it different than MRI fusion biopsy? Who's the right person for FLA? Who's the right patient? What type of disease will he be willing to treat? Who's not the right person or the right patient for FLA? We have that discussion in full length here. And we also discussed this thing that's been boggling my mind. Why isn't FLA a standard treatment everywhere? Why is it so inaccessible? Why so few people in the country, in the United States at least, are using FLA? So what's unique about it? We take a deep dive. And if you haven't heard the last 2 episodes on TULSA and all things, an overview, focal therapies, please do so, because that will give you an overview on how focal therapies work for prostate cancer. And then now here we have another type, FLA, focal laser ablation therapy. So enjoy this amazing conversation with an expert, Dr. Ara Karamanian from Houston, Texas, a proud graduate of Duke. He got a biomedical engineering degree from Duke and then went on to follow his father's footsteps in becoming a physician, an interventional and diagnostic radiologist. So my conversation with Dr. Ara Karamanian on focal laser ablation therapy for prostate cancer. Let's go. Before I proceed, I just want to clarify that this podcast and all Dr. Gio content is separate from my faculty position at NYU Langone Health. The views and opinions on this podcast are my own. Our guests and sponsors are curated by me and not affiliated with NYU Langone Health. Sponsors are a way for us to provide high quality information at no cost to you so that you can take better charge of your prostate health, testosterone, and erectile function, and also how to live better with age. Now, please join me in welcoming our next sponsor.
September is Prostate Cancer Awareness Month, and the Dr. Gio Prostate Podcast is here to help you make informed decisions on your prostate journey. This month, our podcast sponsors are Focal One, the first robotic platform for precise prostate ablation using HIFU. Also sponsoring this month is Profound Medical, innovators of the TULSA Pro, an advanced focal ablation treatment using the TULSA procedure. Click the link in the description to learn more about our sponsors. Enjoy the podcast.
Welcome to the Dr. Gio Podcast. I am your host, Dr. Gio, where it is my focus and intention to help you optimize your prostate health, testosterone, and erections. And as we get older, how can we live even better? With great pleasure, I introduce you to Dr. Ara Karamanian.
It's a real pleasure to be on. Thank you for all the great work you're doing, and let's rock and roll.
Ara, thank you so much. You know, we talked a lot prior to recording, and so we got to know each other a little bit, and it's such a pleasure to actually get to talk to you and in some length of time, significant length of time. I've known about you and your work, God, certainly for over a decade, based on patients who the patients that look for me for natural solutions, lifestyle things for prostate cancer. They're also looking for you because these focal therapies are natural, at least in their head, certainly less invasive than the alternatives.
Sure.
And so many patients said, "Oh, you gotta connect with Dr. Karamanian. Oh, you have to." Well, it only took about a decade or so, and here we are. Thank God to this. So I get to talk to a lot of amazing people and experts from around the world through the podcast. So if for no other reason, the fact that I have this podcast has connected me to great people and great experts like you. So I really appreciate you taking the time to be on.
Well, it's a great platform to have, and it's important to have some independent voices who aren't beholden to certain agendas, who can bring new perspectives, interview people who can give information that you may not hear in the major news medias, or sometimes even from your physician, depending on the
Correct.
particular physician. And as in healthcare, we as patients need to be our own advocates. We need to do our homework, and we need to make informed decisions. And so by having this type of platform and using it towards those purposes, I think you're doing a wonderful thing, and I'm very happy that I can be a part of it.
That's right. And you use the term advocates. And so I call my listeners and people that subscribe to the Dr. Gio newsletter self-health advocates. And so that's the perfect term. And this notion, I repeat it every time. Well, it's in vogue for the layperson to be part of the decision making with their doctors, right? So shared decision making is a term that's used everywhere now. It's only a really good thing, an important thing, if the information you have is adequate and accurate. If not, then it's very difficult to make a shared decision. So this is why we do, and this is why you're on this podcast today. Ara FLA, Focal Laser Ablation.
Yes.
I think my audience knows very little about it, actually, because I have a wide audience, but I can see what their comments and that we've had Dr. Steve Cianti, who you know, on focal therapies, things like HIFU and cryo and other approaches. But FLA, focal laser ablation, they don't know much about. So why don't you give us an overview of what is it?
Sure.
and then we could dive into how it works.
Excellent. Well, there are two parts to it. Maybe I'm diving into how it works right off the bat here, but there's two parts. Think of it like a missile. There's the guidance technology, and then there's the explosion. So first, you need to be able to hit your target. So guiding is extremely important. And how do we do that? Now, if you want to look for cancer inside of the prostate, you don't do an ultrasound. You do an MRI, right? A high-quality multi-parametric MRI. And so we can use a high-quality MRI in order many times to localize where the cancer is. There are tons of studies that show that if you start with a high-quality MRI and then do a targeted biopsy, you'll get more accurate results than if you just do a non-targeted biopsy. And one of the things that blows my mind is that that's just not standard yet. I mean, it really should be standard at this point. Imagine a woman going to a breast doctor saying, I want to get screened for breast cancer. I'm concerned I might have breast cancer. And the doctor says, well, forget the mammogram. Let me just stick 12 needles into each of your breasts. And hopefully, if you have breast cancer, hopefully we'll hit it. I mean, that's ludicrous. Now, high quality prostate MRI first.
That was the case. Even I'm in urology at NYU, and everyone prior to the biopsy gets an MRI.
Good.
You're right. It's not done. It's done in almost every major institution that I know. Maybe you know differently. Certainly not done everywhere, because and you're right about that. 5 years ago only, it wasn't reimbursed. So some people, did it. Some people prior to, and it was like, well, why are we taking so long to do this very important thing? Samir Taneja is one of the premier leaders in this space of MRI targeted biopsies. So here we have this guy. So 5-6 years ago, we couldn't even do it because, or as often as possible as we wanted to, because it wasn't reimbursed. So I really appreciate you saying, let's do things right from the beginning. Let's see exactly what we have before we start targeting, whether with biopsy or treatment
right.
itself.
In either case. Yeah. And one of the interesting things there is that on the insurance side is before, you would argue with the insurance company saying, do you want the MRI before the biopsy? And they'd say, well, does the patient have prostate cancer? And you say, well, we haven't done the biopsy yet. And they say, well, if there's no prostate cancer, no known prostate cancer, we don't want to pay for the MRI. But then how do you find the prostate cancer? You want me to randomly stick needles inside the patient? Let's scan them first. Now, understand, I'm a board certified vascular and interventional radiologist and a board certified diagnostic radiologist. I've used high-end imaging to find tumors in different areas of the body. And I've used that imaging to do targeted biopsies in many parts of the body. That's par for the course for my specialty. And
also, you have a background in engineering.
I do.
So you kind of knew electrical
biomedical.
Biomedical. So right from the beginning, you knew exactly what you probably were. I mean, you had an edge, I have to say, probably. Yeah. With that background, it would make sense.
I was an undergraduate at Duke, I was an undergraduate research fellow in an ultrasound imaging lab that did high-end three-dimensional ultrasound imaging development. And so that gave me a huge leg up in terms of on the imaging and guidance side of things. So the thought that you would just randomly try to, like if you're looking for a liver cancer, you don't randomly stab the liver, you scan and you find it, and then you direct a needle under real-time imaging guidance into the tumor, for example. So now moving that back to the prostate world. So then when we talk about, when there is a little bit of a difference in terminology, which I want to be very clear and specify. When we use the term MRI guidance, once upon a time, MRI guidance meant you're inside an MRI and the MRI was guiding that needle into that lesion the MRI. Yeah. And MRI guidance got a reputation as a good thing, as it deserves. Then some people, a lot of people actually, started to use fusion as MRI guidance. And you can debate the appropriateness of that. So with fusion biopsies or fusion guidance, what they do is they take an MRI that was previously obtained, perhaps 2 weeks, perhaps a month, at some point in the past, and then there's a real-time ultrasound that's done, and then either software, if it's a software fusion, or if it's cognitive fusion, the doctor uses their brain to overlap those locations from the MRI to the real-time ultrasound, and then direct the needle into the corresponding area of the prostate. But let's be clear, they don't have real-time eyes on the target when they're doing that. They have a previously obtained map. So it's kind of like driving a car. You have your GPS. It tells you turn right. Okay, turn right here. But are you going to hit the road or are you going to drive into the ditch? You know, but if you have real-time eyes on the road, you can turn right into the road. So it's kind of an unfair advantage that I have, but I like having that kind of advantage.
So the argument you're making, and I want to kind of re-say what you just said,
sure,
because I think it's very important. When there's two types of targeted MRI, you're saying, no, really, there's only one type of targeted real-life MRI, which is what most institutions are doing these days. Or actually, they're still doing just ultrasound. A lot of places are still just doing ultrasound-guided biopsies today, which is, I would say that's a bit ludicrous, but you can counter that if you may in a second. MRI targeted biopsy, where they use the MRI images and fuse it with the ultrasound, and then some of the areas light up, and those are the areas that are suspicious for cancer. And that's what institutions like NYU and many others do. You're saying, wait a minute, we can do an MRI live while you're having an MRI going on and taking images of your prostate, and do the needle biopsy at the same time while that's happening. My question to you is the following. In other words, the prostate is moving while you're trying to do the biopsy. So you can correct that as well if you have to. But if that's the case, then how do you know that what you're seeing is what it is and that you can catch it while the prostate is kind of moving? I don't know how it moves exactly while the person is still alive. But
totally.
You dive right into a little bit deeper as to what that really means.
Totally reasonable question. And first of all, I want to be clear here. I'm not trying to disparage fusion biopsies.
Sure.
They have a very strong, very good, very real place.
Would you say, first of all, even your opinion is fine, by the way, you don't have to, everything has to be cited here. It is a step above, it looks like to me, in comparison to just an ultrasound guided biopsy,
so there's,
is it not?
Your standard old school transrectal ultrasound with no fusion, that's going to be the untargeted biopsy. Then, as far as targeted biopsies go, there's a fusion biopsy, which is far superior to a truss when done properly, both in terms of the imaging acquisition, imaging interpretation side on the MRI, and then also the fusion needs to be done properly. And so that's far superior to a truss. And then if you need an even higher level of accuracy, an MRI in-bore biopsy is going to give you that highest level of accuracy. So,
which is what you do.
That's correct.
Which we're about to talk about now.
And it's not always necessary to bring that level of accuracy. I'll touch upon that in a minute. So when you stick a needle into the prostate, it can rotate, it can move, the needle can deflect. All those things can happen. Inside an MRI, I can see that relative to the lesion itself. So what I want to see when I do an MRI in-bore biopsy is I want to see the lesion, and then I want to see my needle going dead center through that lesion. So some of us call it an olive on a stick. I want to see my biopsy needle going right through that olive, and I can see it. Whereas with ultrasound, you're depending on the co-registration from a previously obtained MRI, and there's always going to be some misregistration and sometimes significant misregistration between the two. For example, I had a patient who underwent a fusion biopsy, and I asked him what the urologist told him the results were. He said, "Oh, it was great. Everything was benign." I said, "Okay." I asked him, "Did he share with you the findings of the fusion targeted portion of the biopsy?" And the patient told me, "Yes, he did." And he said, "No cancer there." It's like, okay, I'm trying to be as diplomatic here as I can be when I was talking with a patient. And he said, I asked him to pull out the report. He said, "Oh, it says no glandular tissue." Now, if you do a biopsy within a gland and you get no glandular tissue, it didn't even hit the prostate. Now, granted, it was the edge of the prostate, but that means he didn't hit the target if he didn't hit the prostate, you know? Now, again, I don't want to disparage it because it's a very good technology if used properly. And it needs to be much more widely used than it is now. So, but let me talk about where I think the place of it is. So, and part of this, I want to take responsibility as a radiologist. Part of this is on us. See, we in the radiology community need to be doing a better job of standardizing the minimum sort of competency of quality of prostate MRIs. This is very similar, I would argue, to where mammograms used to be, say, in the 80s. Then the Mammography Quality Standards Act was passed, and it put certain requirements, a certain floor and a baseline quality. So now we need to be doing better quality MRIs as a standard throughout the nation. And that needs to be, really, it's the American College of Radiology's place to do that. And they are taking some steps in that direction, so I give them credit for that. And when you look at the quality of them, I've been doing this long enough, and I get MRIs from around the country and around the world. The quality of prostate MRI has significantly increased over the last, so many years. And so I'm very happy to see that. Now, then you also need radiologists who are really well trained in reading prostate MRI well. And I've seen a lot of not so great reads, including sometimes from big name institutions that are prostate quote unquote centers of excellence. Now, I don't know where that term came from.
Many institutions, but except Duke, right?
No, but actually, there's a doctor named Gupta there who's really good. He's a really good radiologist.
Duke does nothing wrong. Can we, right?
Duke is like utter perfection, but we can only just hope and dream to reach that level one day,
Right, exactly.
I went to Duke for undergrad, so
yeah, right. And it's interesting, like your email is Duke still.
Oh, yeah.
It's like, whoa, that's
I'm
that's
a proud
amazing.
Dukey, let me tell you. And the biomedical engineering school at Duke is phenomenal.
Oh, it's excellent. It's well known.
And
well known.
Let me just make a little joke here, which is, there's a little truth in this too. The day they handed me my diploma for biomedical engineering there, I lost a little bit of respect that they would be willing to give me a diploma. It was like, maybe
maybe you're not as good as, right? Well, you were saying before, and not to completely digress, that, as good as you were in high school and as smart, you felt anyway that you were not the brightest when you were at
I can tell you, if you take the brightest engineering students there, I was not one of them.
Interesting. It's fascinating. It's it's a great program. So I had Margolis on.
Yes.
He's a radiologist from Cornell.
I know him well.
Had him on.
Wonderful.
Right? On this podcast. Amazing. And he said we highlighted those problems because when a patient comes to me for prostate cancer, and as you know, I just kind of I wear two hats. One is prostate cancer navigator.
Right.
So you have this, that, and the other. Well, maybe try this A, B, or C. And then is what are the natural things I can do? I can only go by the data. I don't read these slides. I've read 60 slides in my life, which makes me not an expert and not one that I can say, well, I know what I'm looking at. I don't. I'm banking it completely on what that report says.
Right.
And if that report is wrong, then all bets are off.
Yeah.
Now, Margolis said, there will be a certification that people can opt for. They won't have to, right? And like a prostate cancer, MRI imaging certificate, whatever. And that people can kind of say that and promote that. And that's what they're working on. Because I think it's important. You have a radiologist. Well, they're looking at prostate, they're looking at breast, they're looking at lung, they're looking at everything. So they're not that focused and experts in prostate specifically.
So my feeling on that is I mean, look, I don't know the details of what the plan is there, but one of these weekend or 1 week courses, if that's what it entails, it's grossly inadequate with all due respect, if that's what it is. And again, I don't know the details. My view on it is it really should be a formal board subspecialty of radiology. You can't go and do a 1 week course on women's imaging and now you're a women's imager. You do I mean, it's a certified subspecialty that requires a 1 year fellowship where that's pretty much all you're doing. And that's how and believe you me, I don't think reading prostate MRIs really well is any easier than reading mammograms. You know, I'll leave it at that.
I mean, I've seen power ads go from 4 to 2 or 2 to 4, either way, read in one place, then read somewhere else. It's like, whoa, that's a huge.
Yeah.
Like,
and it gets harder than that. Like, for example, I have seen. So PIRADS is really an oversimplification, but it's a necessary oversimplification, and it's a good system. I'm not disparaging it. Please don't get me wrong, but I think the radiology community needed to create a simplified system that's understandable, but it's so much more sophisticated than that, so much more complicated. I've seen PIRADS 5 lesions where I'm like, this is not cancer, and I've seen.
Hey, friends. Help me welcome yet our next amazing sponsor, Profound Medical. They're the producers of Tulsa Pro, another focal ablation treatment. Profound Medical is at the forefront of revolutionizing prostate disease treatment with transurethral ultrasound ablation, or TULSA procedure. That's within the urethra. That's the tube that brings out your urine and semen. The treatment occurs through that urethra, not through the rectum. This incision-free approach targets and destroys prostate tissue from the inside out, aiming to reduce the risk of complications such as erectile dysfunction and incontinence, while ensuring that there is an effective oncological control with a swift return to daily life. By integrating real-time MRI with advanced robotics, TULSA offers a highly customizable solution, precisely targeting the entire prostate gland or specific areas, setting a new standard in prostate care. To learn more about Profound Medical and TULSA Pro, please go down to your show notes and click the link. Wow,
yeah, and
that's a huge.
And I've seen,
because there's almost 80% chance of not only cancer but Gleason 7 or
okay,
higher.
yes, but if you look at on the population level, that's true. But and then I've seen PIRADS 4s where I'm like, oh, this is not good, you know. So it's really interpreting these. There's much more to it than giving it a number between 1 and 5. There's a lot more to it.
Makes it simpler, but I can imagine.
And then let's tie it back to the biopsies, like we were talking about. There are, I think, part of the role for the radiologist in this, if we have a proper men's imaging subspecialty board certified, level, like that level of training radiologist, there are some other skill sets that they should have that are important here. So, for example, there are lots of patients where I've looked at their MRIs and I say, okay, a fusion biopsy is more than adequate for you. That has plenty of accuracy for your situation with your MRI, with your prostate, et cetera. Then there are ones where I'll tell them, look, you want to do an MRI and bore biopsy on this because a significant percentage of the time, a fusion biopsy is going to miss. So, for example, there was a guy I can remember who had a very enlarged prostate, and he had a 5 millimeter lesion. I mean, it's small. This was years ago. 5 millimeters is a small lesion, and he had a very large prostate. And with a fusion biopsy, they were going to. Chances were that they were going to miss that lesion, or if they hit it, they would hit it on the periphery and undergrade it. So one of the problems that we have in terms of Gleason 3+3s is that half the time, if you do a trust biopsy, you get Gleason 3+3, depending on which article you read it, about half the time, it's actually a 7 or higher when you do this surgery to remove the prostate. So I've had lots of cases where
that percentage is less though with targeted
absolutely
fusion,
because fusion is going to be much more accurate than the older approach. But we need to bring an even higher level of care there, where we can say, okay, this one you need more accuracy than a fusion is going to provide. So in this person's case, for example, we went straight to an MRI and bore biopsy, and it was a Gleason 9. And you know the significance of a Gleason 9, high risk cancer, you know, and we caught it when it was 5 millimeters in a prostate that was very large. That's awesome. But then you need to, I think we need to train an army of radiologists who can then, okay, they can look at the prostate. They can think it through more than just the PIRAD system. Then they can direct the patient to the appropriate type of biopsy for their situation. And they need to have the skill set to do an MRI in-bore biopsy.
That's a lot.
Yeah, and you're not going to learn that in a week.
By the way, how about this? How many, first of all, you said there's a couple of things. Number one, you are also a trained diagnostician, radiologist, and also an interventional. How many of you are there there? I don't know.
Okay, so actually, I pretty much all, I mean, there may, I mean, it's either all or just about all board certified vascular and interventional radiologists are also board certified diagnostic radiologists. It's an additional subspecialty of radiology, although it's switching now to become its own specialty, but it's still
that maybe that's a confusion, because I was like, it's not my field. So I don't, well, thank you for clarifying that.
And
then how many, okay, so great. Dr. Karamanian, I live in, I don't know, Utah, whatever. Sure. How many of you are out there doing this? I don't know many of you that are doing these in-bore MRI, and certainly no urologists.
So there may be one or there are, I think I can think of a couple of urologists who will do an MRI in-bore biopsy. But understand, MRI guidance, like, okay, when I in-bore MRI guidance, so that term was born the in-bore term was created in order to distinguish between live MRI guidance and fusion guidance with an MRI that was previously obtained.
Got it.
So
that's what the term means, that it's live.
Yes.
The MRI biopsy.
So in-bore, because you're actually inside the bore of the MRI, and
oh, thank you for
at
that.
the time of the biopsy. So in-bore real-time MRI guidance, that's not in the natural skill set of a urologist. I mean, look, I mean, I'm a board certified diagnostic radiologist. Do you have any idea how many images I've looked at? And then to do, I mean, that's years and years of training just in and of itself. And then the interventional side of it, being able, there's all sorts of skills that takes. Now, you throw me in an operating room, can I cut somebody open? I'm not the guy you want doing that. Although, simple things like a port catheter, I'm very good at doing those. But like a prostatectomy, I'm not the guy to do a prostatectomy because I don't have that surgical training. Now, it's easy to think, MRI guidance, that's, it's natural, it's easy, but I'm telling you, it's not to do it really well. And so, but that's the realm of a vascular and interventional radiologist. That's our specialty. And that comes after years of training on the diagnostic side, plus additional training on the interventional side. And so that's urologists can do some of these things, but when it comes to real live MRI guidance, like we're the experts at that. And
right. But even you, that's what I'm saying. That's my point. Even radiologists, there's just very few that are actually doing this. And I wonder why.
I'll tell you.
Is there a data other than you could say? You could tell us a dirty little secrets why that is too, by the way, if you want to. But also, are there papers written on this that are, because I don't remember seeing a whole, comparing the two, or just even on in-bore MRI guided biopsies, just in general.
Once upon a time, all the papers on targeted biopsy, on MRI guided biopsies, were all in-bore guided. It was all data from in-bore live MRI guided. And we didn't use in-bore or live terms because MRI guided meant inside the MRI. And as an interventional radiologist, when I think of MRI guidance, I'm thinking live. There's no such thing other than live MRI guidance. It's just that's what it is. So
That's how you define it in your hand, and that's it. Period. End
yeah,
of story.
so that's where all the original papers on this, they were all in bore MRI guidance. None of them were fusion. Fusion came later, much later, as a consequence of trying to make this more broadly available, more widely available to more people. How can the technology develop in such a way that we can put it in the hands of urologists so that they can also do targeted biopsies? Because look, we need to all, if we all work together, we'll be able to get better results than if we're in our own separate sections. And B, so now there's some political and turf issues here. There are going to be urologists who feel like interventional radiologists have no place in touching a prostate. You can read an MRI, but don't you dare go any further than that.
Yeah, keep it
Yeah,
there.
keep it there.
Just read it. Get me the results.
Yeah, but let me tell you something. There's a very important principle in women's imaging, and I would make the same argument for men's imaging, which is doing rad path correlation. So radiology and pathology correlation. And that can be done much more effectively when you have an extremely high degree of confidence that you hit your target. So what do I mean? I mean, you get the MRI, you look at it, you're like, gee, is that cancer? Is that not cancer? What could it, And then if you stuck a needle directly through the middle of that guy, and you have a superb prostate pathologist who's reading it, that you have each other's phone numbers on speed dial, and you do enough cases like that, you become much better at reading those prostate MRIs to know what's what. Now, the more uncertainty you put in the accuracy of the targeting, the less valuable that becomes, because you're like, well, did I miss it, or is it really not cancer? So that sort of in-bore targeting, and then going back and looking at the MRI and asking, does this make sense, and looking at those images, et cetera. See, that's what needs to be done in a men's imaging fellowship. It can't just be look at a bunch of images and get no feedback in terms of what's what. You need that rad path correlation. And for the tricky ones, it's important to have that option. I mean, look, I've seen guys who have gone biopsy year after year, including sometimes targeted biopsies, and they come to my office and I'm like, you know what, I'm sorry to tell you this, but you have stage 4 prostate cancer. And they're like, are you kidding me? I did everything the urologist told me. Well, sometimes blind biopsies certainly fail at times, and sometimes targeted biopsies fail. Fusion targeted biopsies, and it's certainly possible. Look, nothing's perfect. An MRI and bore biopsy can fail too, but you have the images, you have them recorded. You can see, did you hit it or you didn't hit it? It's there for the world to see.
Yeah, it's live. Yeah.
It's live. So, but to get to that level of expertise, no, there aren't a lot of people here who have that sort of level of expertise. But I think it's incumbent upon the radiology leadership to encourage, enable, and develop and nurture and back up the people who want to develop these type of fellowships, to train a whole crop of radiologists. And then we need urologists who are going to feel comfortable working with us in both directions, where we get where they feel comfortable referring patients to us, they feel comfortable letting us do some of the biopsies, and they trust us enough to know that we're not going to overplay the MRI in bore biopsy, because there's certainly cases where a fusion, many cases, if not most cases, a fusion is good enough. And so there needs to be a certain level of trust there, where we can work together more effectively than we can separately. So now
I'll wait for that day. I'm optimistic.
So now I've talked to lots of radiologists about this, and one of the big concerns is that most interventional radiologists are tied to a diagnostic radiology group. And if the lion's share of their income comes from referring physicians, referring patients to your imaging center, and you can't upset those referring physicians, or they'll they'll stop sending you patients to do your MRIs and ultrasounds and CTs and X-rays, et cetera. So a lot of radiology groups make a strategic decision that they want to stay outside of this space because they don't want to risk upsetting referring physicians. And so and that's holding this area back, unfortunately.
All right, let's dive in if you're ready for it. All right, so you got the diagnostic.
Yes.
So you do both. You do the diagnostic with in-bore MRI-guided biopsy,
As appropriate.
and then we know they have prostate cancer.
Okay.
Let's talk a little. Now let's dive into FLA a little bit more. How does it differentiate with everything else that's out there? When patients come to me, they're confused, and I'm like, I get it.
Of course. So
so too many. It used to be we had very few options: radiation, surgery. Now we have too many options. So how does FLA fit into this whole thing?
So the MRI, now I need to talk, I talked about the guidance in terms of real-time visualization of the tumor. There's one other part about the MRI guidance, which is like mind-blowingly phenomenal. To this day, I'm in awe of this. And I can get into the technical side, but let me keep it simple for the purposes of this conversation. The MRI can actually can create real-time temperature maps in multiple planes as you're doing an ablation. So not only can you see the target, you can see the temperature that the laser is creating in real time in multiple planes as you're doing the ablation, which then further allows you to even more precisely lay down that laser energy, creating those ablation zones to the way that you want, because you have those real-time temperature maps. Now, with ultrasound, there are some attempts that some companies have made to try to make something of a temperature map, particularly using like an acoustic impedance. It's a far inferior technological approach, but they're trying something, which is good, that they're trying something there. But having those real-time heat maps in multiple planes is enormously beneficial. So now
you're going to have to really explain what that all means, because the audience doesn't know how FLA works. Like why does that matter?
Sure. So just like I can put a needle guide in the patient's rectum, which is about the diameter of my index finger. I can angle that and position it pretty much however I want. And when I find that angle lines up with the tumor, I can put a biopsy gun through it and take a sample of the tumor. Well, I can also put a laser fiber through that needle guide, which is only a touch wider in diameter than a biopsy gun. I can put the laser fiber into it, and that laser fiber is a fiber optic that connects to the laser system, and it can transmit that laser energy into the prostate where I want it. And the MRI gives me that real-time feedback in terms of, okay, where am I heating up the tissue and how hot am I heating up that tissue? Now, the reason why men have issues with erections after a radical prostatectomy is there are these two nerve bundles that run just outside of the prostate. And those nerve bundles are fragile. I mean, one of the great things that Dr. Walsh, the famous Dr. Walsh, proved was that you don't even need to cut those nerves. If you just tug on them, you can break them. I mean, they're that fragile. And so you can leave those nerves hopefully alone and direct the laser energy into the parts of the prostate that you want with tremendous precision. And having this precise laser system, which by the way is also FDA cleared for use in the brain, just to give you an idea of how precise it is, and having the MRI, the real-time MRI temperature map. So you have the guidance in terms of where the cancer is. You get real-time temperature maps in terms of where that laser energy is going and how much it's heating up the tissue. And everybody's body is different. Sometimes you need more energy. Sometimes you need less. Sometimes you need it for longer. Sometimes you need it for a shorter period of time. You want to be able to get that cancer covered plus a margin, that's the goal, without hopefully hitting that nerve bundle. And that nerve bundle is fragile and it runs just outside of the prostate. So you need as much precision as you can get in order to do that. And the MRI giving you that real-time feedback of what the actual impact of that laser fiber is to that prostate in real time, then allows you to control the laser to get more precision. So there are some efforts that have been done and are being done to try to do ultrasound guided focal laser ablation. It's difficult for me to imagine, knowing how hard it is to do quality work.
Is that to reduce costs? Why do ultrasound focal laser?
Urologists are much more comfortable with ultrasound than MRI guidance.
Yeah,
It's faster, it's cheaper. But I really struggle to try to imagine how that can be done with. I know how hard it is to do it with all the benefits of real-time, high-quality MRI guidance. To try to do that with ultrasound guidance at the same quality level, I mean, maybe it can be done, but I have trouble seeing it.
Have you found that there's an ultrasound technology that is out there now that they're looking at that is way more precise and blah 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 and blah 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 than what's already out there, right? It's almost like it has like something similar to or analogous to a PIRAD score. So they call it something different, but it's a 1, 2 to 5. Forgot the name.
I think you're referring to ExactView.
Maybe ExactView.
Yeah.
So what are your thoughts on that? And what are your thoughts on where it can go? Is it remotely possible that the ultrasound could be, let's just say, not as good as an MRI, but... Hey, friends, please help me welcome one of our special sponsors, Focal One. When you're trying to choose and be part of the shared decision-making of, what's the best focal therapy for me? Assuming that focal therapy is the right approach for you and your prostate situation, ask them about Focal One. Focal One is the first and only robotic platform for precise focal ablation of prostate tissue using high-intensity focused ultrasound, or HIFU. This minimally invasive technology offers prostate cancer patients a game-changing treatment with no surgery, cutting, or radiation. With unmatched precision, real-time imaging, and advanced software for MRI fusion, Focal One ensures faster, safer, and more effective treatment, sparing healthy tissue and minimizing side effects. Treat the suspicious lesion in your prostate and leave everything else alone. Next time you visit your urologist and you're talking about your prostate cancer, if that's what you have, ask them if you are, number one, a candidate for focal therapy. Number two, if they use HIFU, ask them, are they using Focal One? To learn more about Focal One, please look at the link below in the show notes. Well, pretty darn close, and then it's a lot less expensive.
So my experience, first I want to qualify this saying my experience with ExactView is limited, although I think I understand the physics behind it, or at least a significant part of it. I've seen cases where ExactView has been able to pick up a lesion that the MRI missed, which was impressive. But by and large, again, this is anecdotal, and so I have to give all sorts of qualifications there. But by and large, I think that the MRI is going to win. If you have to choose one, the MRI is going to win out. Maybe it's worth doing both in patients, especially if it can be done cheaply in office, and then you get the MRI. There may be room for that as well. So that uses a high frequency ultrasound, but it also has difficulty. High frequency ultrasound has difficulty penetrating. It's just like if your neighbor's throwing a party, what sound do you hear? You don't hear the high frequency sounds, you hear the low frequency sounds. So the low frequency sounds penetrate more, but your spatial resolution is lower with lower frequency. And ExactView uses like really high frequency ultrasound to be able to see what they're trying to see. And so there's some limitations in terms of just the posterior part of the prostate or not. Well, I can't say just the posterior. I'm not sure how far up in the prostate it can get through, but in a larger prostate, it certainly can't get to the front effectively. So that's one limitation. Fundamentally, what I would need to see is like a controlled data set where you have a bunch of patients who get screened on one screen, who get both sets of images. And maybe there's a study out there. It could be, I'm not sure, and, I wouldn't be against participating in something like this if ExactView would like to, do a study like this. If they, assuming they haven't already, maybe they have, but you really need a large data set where both are done and you have high quality targeted biopsies, so you get some accurate ground truth in terms of what's going on in those patients, and then compare the two. But that's the guidance part of the technology in terms of seeing the target. But I really don't think, again, my opinion, but I really don't think you're ever going to be able to get any version of a temperature map with ultrasound just based on the physics limitations that come with sound waves versus what you can do with an MRI.
Explain again. So now that we have an idea, so FLA,
Yes.
right? So I'm going to repeat some of it. You have a sort of a rod the size of your index finger that goes into the rectum, just like they do for biopsies. And then you have a laser fiber optic. Yeah, there it is. Thank you. Show and tell.
Yeah. And
Show
then
and
there's
tell.
Now I actually used this in a patient years ago.
So for everyone, if you're listening to this on Spotify or Apple Podcast, you watch the YouTube channel. You get to see what these laser fiber optic instruments look like.
So I actually used this in the patient. It's a little beat up. I cleaned it off really well when it was done.
I hope so.
And then you can see it extends to the fiber optic part. And this is actually a fiber optic cable here. And that extends to the laser system. So you can see it's not much wider than the biopsy gun itself. And it emits, at the distal end of it emits a roughly grape-shaped, not exactly, but ablation zone that goes out in 3 dimensions. So you need to understand the 3-dimensional space of that particular patient's prostate, the edges of the prostate, the cancer, the 3-dimensional edges of that laser, the laser energy. And you need to, and the prostate can move and shift and angle and change their angle when you puncture it, and all those things. That's again the realm of an interventional radiologist to be able to put that all together. And it's not enough just to be an interventional radiologist. You really need to be subspecialty trained in this particular area, because there are plenty of things that are unique to it, and you need to understand. But and
what that emits is pure heat.
No, it emits laser light in the 980 nanometer. It depends on which system, but the standard system, it's 980 nanometer wavelength of laser light. And then that hits the tissue and that gets absorbed, and then that gets turned into heat.
Got it. And so you insert that instrument sort of, or at least in the middle of the actual tumor, perhaps, and then emit some laser around it. So where does that needle go, and how far around that tumor do you go?
So it's more complicated than that. I'm taking some liberties to simplify things as I'm saying them.
Yeah.
So if you have a lesion, the one of the great things about the system is it's very precise. Part of the cost of that is that it gives relatively small ablation zones compared to, say, cryoablation or microwave ablation or radiofrequency ablation. The ablation zones are going to be smaller, but you can. I'd rather take longer and not burn out the guy's nerves.
Right.
So the approach that I'll generally take, and it varies patient to patient, anatomy, the prostate, the cancer. I won't start in the middle. Although when I do a biopsy, I'll hit the middle, and then I'll go out a little. I won't take samples of all the exact same spot. I'll hit different parts of it. With this, the idea is you want to create an ablation zone that covers the tumor and gets a margin beyond the edges of what you see on the MRI. There was some very good research done out of UCLA where they demonstrated the MRI pathology correlation in terms of the size of what's seen on the MRI versus the size of the cancer in reality. And you do need to extend out the ablation zone beyond what you see on the MRI. So I won't start in the middle. I'll start at one of the edges, and I'll work a grid pattern. It's also important not for the grid spacing not to be too far apart, because if it's too far apart, you can leave viable cancer on the inside. And what makes that even more challenging is that the prostate will rotate, it'll curve, it'll this, it'll that, it'll compress, and so you need to be able to, cognitively in your mind, you need to understand all of that so you can place the laser fiber. You can see the tumor, you can see the laser fiber, but you need to be able to know all the different positions where you're placing it so that when you're done, you have a good ablation zone. And one of the things we do at the end, which is another huge benefit of doing this in bore, is that you do a contrast enhanced MRI at the end. And there's very good research that shows that the area that was destroyed with the MRI matches up, or with the laser, matches up very nicely with the area that is not enhancing. You take contrast, you mix it with the blood. Wherever there's blood flow, there's contrast flow. The places where there's no contrast flow, there's no blood flow, which means you killed it. And then you look at that, you see, okay, did I cover the areas I wanted to cover? And do I have a good margin? And once in a while the patient's still on the table, if you feel like you could have extended a margin better in one direction, or a couple if you need to, you can go in and do another ablation while the patient is still on the table and extend that margin. So when you're trying to split that difference between hitting the edge of the capsule and not hitting that nerve bundle, and you see, I left a little sliver of tissue there, you can do another ablation where maybe you take it a little closer to the nerve bundle if necessary. Or, I thought I extended this ablation zone a little higher. Let me do one more ablation a little higher to do my best to try to make sure I have a good margin, in every direction.
And so how long will it take you to do, let's just continue to keep it somewhat simple, that one tumor that you're talking about? How long will
Depends
that
on the size. If it's an 8-millimeter tumor, it's usually pretty quick. If it's a 2.3 centimeter tumor, it takes longer. And it also depends on the configuration of the tumor. And there are certain angles that require more ablations to be able to get coverage versus others that are just more inherently natural in terms of your angle of approach. And then, by the way, there are other things in terms of patient positioning to try to angle things right to maximize the chance of getting the cancer without hitting the nerve. And so there's that part of it too. And all these things need to be taught, and it's pretty extensive. So it's not a.
I could see why there are very few people that do this.
But there are things in interventional radiology that we do, like a TIPS procedure. That's a complex procedure. And that takes a lot of expertise and training across different things. It's not something we can't learn to do. It's just you need to respect it and put in the time to do it. And so when I hear of a urologist, I'm going to get in trouble for this, but when I hear of a urologist trying to
Is this the part that we need to edit out, Ara? Just let me know in advance.
I'll let you.
Don't forget, my boss is a urologist, so please be gentle and be
Fair
kind.
No. And look, I have a lot of respect for all the things that urologists have accomplished and continue to accomplish, and I have a lot of respect for the fact that they're now, by and large, embracing image guidance, and that's wonderful. The thing is, when we get in trouble in medicine, when we go beyond our skill sets, and look, maybe there are compromises that need to be made in medicine where this just rubs me all sorts of wrong, but maybe there are places in medicine where, oh God, it's hard for me to even say it, but maybe there are places in medicine where suboptimal
stay in your lane.
It's not so much that, it's where it's suboptimal. Medicine may be the appropriate target for the field of medicine. I mean,
that doesn't
sound right, but yeah, but so when I think of ultrasound guided laser ablation by somebody who doesn't have as extensive of training, like not like a quarter the length of training and experience of doing image guided procedures, and to use ultrasound to guide a laser to destroy. I mean, maybe if it's a really easy case, okay, fine. But you see, that's why I know how hard it is to do this well with the tools of MRI guidance. It's hard for me to imagine doing it at that same level of quality if it's done by a urologist who doesn't have a lot of extra training in image guidance and done with ultrasound guidance. Like, I couldn't do it as well ultrasound guided as I can MRI-guided. I just can't. It's just, I don't think it's, but again, that's my opinion. And but we do need to be practical in terms of making the technologies available for a wider audience. So it's, and now how you do that at a systems level and get the insurance companies on board and get the government on board and get urologists and radiologists all play together in the sandbox together, like, well, you know, I mean, look, we face a similar situation as interventional radiologists when it comes to uterine fibroid embolizations. Uterine fibroid embolization, I'll be very brief on this, but that's, I believe it's an underused technology that allows a woman to be able to keep her uterus when she has fibroids and too much bleeding. For many patients, it's a good approach. It's about 80% effective. There's tons of data on it, so nobody can say, oh, we need more research. And yet there are gynecologists who won't share that option with patients, or if they do, they kind of blow it off. And I think that's unfortunate, but you know, what I'm trying to say is this issue is not just in this area of medicine.
It's not only about science and efficacy. There's more to it than that.
Yes, there is. And we need to solve all those problems and figure out how to work together, all of us together, including the insurance companies, so that we can provide what's the reasonably best care we can for the patients who trust us with their health.
Right. And that's ultimately that matters, or should matter at the end of the day.
And maybe, by the way, maybe let me just say this also, maybe I'll be proven wrong. Maybe there are people who can do ultrasound guided laser ablation as well as a top guy doing MRI guided laser ablation. You know, I hope people prove me wrong there. And I'll tell you, and you know what? I hope that we come up with some sort of immunotherapy or something amazing that you take some blood cells, teach them how to fight prostate cancer, re-inject it. And I mean, I would love to see a great, easy cure for prostate cancer with no side effects that's very efficacious. I would love to
a natural approach, Ara.
Please. I would love to see that. Believe me, there are plenty of other areas of interventional radiology that I can do a lot of great work in. I would love to see those kind of advances in my lifetime.
The example you mentioned before of everything that it takes to get rid and ablate that tumor, it sounds like to me like it's a little bit lengthy. So at what point, how many of such tumors, what's the limited amount of tumors that you could treat at one time? Do you do these all one at a time, or is it all let's say they have 6 tumors that need to be treated, do you do them all?
Well,
how does
now,
that work?
when you say 6 tumors, let's define our terms a little bit here. So, for example, if you have one MRI lesion in the left apex, and it shows, and the biopsy shows cancer in the left apex, left medial apex, left lateral apex, and left medial midgland, and it's all from that one lesion, are we calling that one tumor or 3 tumors?
Maybe that's just like one. Maybe you treat them all.
Right? No. You would, you know, if they're all, So if we're calling that one tumor versus, because sometimes people will say, oh, there are 3 tumors, but it's really one.
I see.
In many cases, not all cases, but
correct. So if the location is not that close to each other where you can't kind of count them as one, they're a bit far from each other, and there's, I don't know, what's the limited amount of tumors that are not close to each other that you're able to?
You also have to factor in the size of the prostate, because there's sort of you're ablating a certain amount of space with each ablation zone that you create, and then you do multiple overlapping ablations. If the patient has clinically significant prostate cancer throughout their whole prostate and they have a big prostate, laser is not the right option for them. And I don't want to offer this to patients, and I don't think I offer this to patients for whom I don't think it's a good option for them to consider. Now, but then let's talk about something else. Let's say they have an index lesion. They have one clear-cut Gleason 7 tumor in one area of their prostate, and then the non-targeted portion of the biopsy shows 2% Gleason 3+3 in 3 other areas of their prostate. for the
Do you leave those alone?
well, it depends on the specifics of the situation. Is it right next to the nerve bundle where the risk benefit may not be worth it? How old is the patient? What are the patient's desires in that, in terms of would they rather? I mean, you need to factor in, and you need to have these discussions with the patient. What they're looking for and the approach they want to take. Would they consent to leave those areas on active surveillance or not? And there are patients who say, I want all of it out. And I can tell them, with that distribution,
Risk reward.
I really can't come close to making that guarantee.
In that scenario, so here's how we worked. You and I work together, Ara. If no one else works together, you and I work together. You leave those Gleason 6s alone. You send them to me, and I'll put them on an aggressive lifestyle intervention practice that is doable. And how we prove it or not prove it is a different story, but there's a lot of data to finally suggest that there could be some regression of prostate cancer with prescriptive exercise. So that's the thing, right? It's not, hey, go exercise 30 minutes a day. It has to be more prescriptive than that. And I'm getting really close, plus the dietary elements and all these things. So, by the way, this is a true story with a lot of the focal guys in the community. Oftentimes they leave the Gleason 6s alone. They send them to me. I put them on aggressive lifestyle intervention, and they tend to do very well. Whether that Gleason 6 disappears or not, yeah, sometimes they do a follow-up biopsy, no cancer. I'm not saying that, well, this cured this Gleason 6. I'm not saying that. It could have been missed. But I'm saying if the PSA is, in a focal situation, if it's stable or very, very low stable, and they do a biopsy by the same surgeon who shows that there's nothing there, could have been missed, but that's a good situation. And Scott Egner would say that Gleason 6 is not even cancer anyway, so why are we worrying about it?
And if you have an MRI in there that doesn't show a clinically significant lesion, or it doesn't show a lesion on top of that mix, then that's a win. I mean, that's a huge win. And they got to save not risking the side effects of surgery or radiation. Although I do want to be clear, there are risks that come with focal therapy, and those risks are real. And I have made men impotent with the laser, but the chances are much less than surgery or radiation. So, but it's certainly not without risk.
Ara, I pose this question to everybody that comes to the podcast, right? So you have a guy that comes in with a Gleason 9. PSMA scans show, yep, everything is encapsulated. MRI shows, yep, there's nothing outside of the prostate. When is a cancer just a cancer? Whether it's Gleason 10 or Gleason 6 or Gleason 7, and you just say, yep, I can treat that with focal, with FLA or with any other technology. What are your thoughts on that? When do you say, yeah, no, I can't? Gleason 9s, like, where do you draw a line? I'm saying a big part of what I do sometimes is what out of the box thinking, right? Because things are not textbook.
Oh, for sure.
The patient that comes in is not textbook. What out of the box thinking makes sense, makes scientific sense? And if the patient is aware of the risk and reward and the fact, look, we don't know if I treat this Gleason 9 with FLA, I don't have any data, but I think that based on what we have, we could take the chance. When can we do that? And what is your approach with FLA and higher grade Gleason scores and prostate
That's a
cancer?
great question. First, I want to be clear in terms of, I'm a big believer in patient autonomy and patient decision making, and that it needs to be informed decision making. And my role isn't to make the decision for the patient; it's to inform the decision, sometimes thoroughly and at length, to help them make the best decision they can make for themselves. Because in so many of these cases, it's not the science dictates this is the right decision to be made. There are areas of medicine where that holds true. This, by and large, is not one of those areas. And we have data that's obtained scientifically, and then applying it to these situations also needs to factor in a lot of the values of the patient, what the patient's goals are, what the approach they want to take, because there's no clear cut right and wrong in so many of these scenarios. So take that Gleason 9, right? First, you brought up the MRI shows it hasn't broken out of the capsule. The PSMA doesn't show any evidence of spread to lymph nodes or bones. Okay, let me challenge that a little bit. What are the chances that just because the PSMA is negative, it hasn't already gone to a lymph node? It could have still gone to a lymph node. Not only that,
micrometastasis.
Yeah, micrometastasis.
There could be micrometastasis, but if it wasn't that there's now a PSMA and it seems to be really good before what we had before, I would say, listen, Gleason 9, there's a better chance. PSMA not showing lymph nodes, yes, there's still a chance. And if it's if I'm the patient, let's say, yeah, okay, I'll take my chance. But if the PSMA, pretty good technology these days, thank God we have it. If it shows nothing, all right, let's take this
by the way,
chance.
I'm a huge believer in PSMA, and before that, C11 acetate. And for the record, if I'm not, I don't think I'm mistaken on this. It's possible I am, but I think I am okay. Maybe I think I am, but I want to say it too strongly because maybe I'm not. But I think I was the first person to order a PSMA PET CT at UCLA for a very specific patient in a very specific scenario, way back, like right at the beginning. So I'm a huge proponent of PSMA. Let me be clear. Now,
without them having to be on a trial, because that was the deal back then. They had to be on the trial to get one. Unless they paid out of pocket, if I remember. 'Cause I had a similar scenario back in the day because I was following the research out of Germany, and I was like, wow, this thing is good. And then I was hearing, oh, here Sloan had it but only for trial purposes. So I was like, get it, and if you can pay for it, it was expensive. But some people said, yeah, it's worth it. Yeah, I felt the same way.
So now, I'm a huge proponent of PET scans. I think they should be PSMA PET scans. I think they should be used much more widely than they are even now. And now, having said that, I want to talk about, well, what are the chances of those micrometastases? Because the technology is very good, but again, look, I'm a board-certified diagnostic radiologist. I've got some expertise on this.
If you don't see it, if you don't see it, I think that that would give me some ease to say, yeah, that's a good way to
go. So the scenario I would paint here to sort of prove my point is, if you have somebody who's undergone a radical prostatectomy, so their PSA should be 0, and their PSA comes back at 0.5, what are the chances that PSMA PET CT is going to be positive? Now, for a fact that they have a micrometastasis, at least a micrometastasis in that case. Yeah. And if their PSA is 0.5, what are the chances that PSMA, I'd have to look up the data, but
I don't know the data, but it's pretty. Let's just say what I've seen is pretty. At 0.5, that's the benefit of PSA. That it could catch things like at a very low PSA. Correct. Yeah, and yeah. So I think it's pretty darn good relative. Again, I'll be pulling numbers out of the air, but
it's a lot less than 100
based on what I've
seen. It's a lot less than 100%.
Yeah. Sure.
And we know that they have micrometastases. Yeah. So the issue there are a couple different schools of thought when it comes to these high-grade cancers. Well, first, if you have surgery, they can do a lymph node dissection at the same time, even if the PSMA is negative. If I had a Gleason 9 and I was to undergo, let's say I was to undergo surgery, I would want them to do a lymph node dissection at the time of surgery, because that's not only diagnostic, it's therapeutic, because if there's Mets there, they can get those micrometastases out with those lymph nodes. So that's one disadvantage of doing focal therapy in the high grade and even intermediate risk prostate cancers, or unfavorable intermediate risks. Another situation is, let's say you have a guy who's 84, otherwise pretty healthy. He says, I don't want to take a significant risk of, the side effects that may come with surgery. Can you slow this thing down? Well, I can't guarantee that I'll slow it down, but I can destroy at least the vast majority of the cancer that's in the prostate. If it's a relatively, like, let's say it's a 1.5 centimeter Gleason 9, right? But I'm not going to promise that patient that, I'm going to be very limited in terms of the promises I'm going to make. But but look, I've had guys who have told me, Dr. K, I don't care. I'm not having surgery. I'd rather die. Right. So now in that scenario.
So that's correct. So I'm specifically talking, personality type matters, mentality
Absolutely.
matters with the patient, right? They're the patient, you know them well. I'm the take it out guy. Ara, I'm not kidding. I had a patient, biopsy negative. Hey man, congratulations, biopsy negative. Oh, no, I actually want a positive because I want my prostate out, and then they won't take out my prostate with it. So why? My father had prostate cancer. I know I'll get it. Second biopsy negative. He was upset. Third, fourth, eighth. They found a little tiny Gleason 6. Great, high five. Take out my prostate. So there's those guys, and then there are the guys that are under no circumstances am I taking out my prostate. Period. End of story. And so in those cases, okay, there are no studies to support this. PSMA negative, Gleason 9, MRI showing that it's encapsulated. Once again, I guess my bias, treat it with FLA, aggressive lifestyle interventions with, as best as I don't know that it treats cancer, but it creates a microenvironment that's hostile to cancer. Let's see what happens, right? And let's see, micrometastasis. Don't we all have some micrometastasis around in our bodies all the time anyway? And our body does something in a healthy body too. I mean, there's some theories around that I think might hold up. Go for it, and they know the situations. And if this fails, then you can say, look, we'll have to do B and C. But I think that's a good scenario for the person with a different mindset. I don't know if it's right or wrong. But where they say, look, I'm not doing it, but I do want to do something, maybe that works. Do you see cases like that? And I'm sure you do, actually. Sure you do.
And I think it's very important that the patient be informed well and understand those risks.
Yeah.
Understand the data and understand the limitations of the data we have. Believe me, there are a lot of research studies that I think should.
And this is why out of the box thinking is appropriate, done right from the right person. There's a lot of kind of things you got to check off because there's crazy things going on out there. I remember a guy out of Florida treating patients with HIFU back in the day without a biopsy, without anything, based on probably imaging that he didn't read well. So there's all kinds of quackery things going on. But I think done right, knowing the risk benefit reward ratio or what, risk benefit reward ratio, the right patient, right mentality, they care about the quality of life. They love their sexual life and all these things that they care about. Quality of life matters quite a bit. I had people on talking about testosterone and after prostate cancer. Man, that's a big deal. Not to digress again, but that's a big deal. We're talking about quality of life. It's not only, some people will tell you very frank, look, I'd rather enjoy the next 5 years of my life than live 10 years under, miserably and so forth. So, yeah, I think that's why I posed the question, and that's a good answer.
It really comes down to the individual patient, the circumstances. And so, as I said, I view it as our role to inform them and to help them be able to think things through. And so they understand the situation, they understand the implications, and then help them make the best decision they can make for themselves. And sometimes that involves my services and sometimes it doesn't. But either way, that's providing, I would argue, I think a good service to those patients.
All right. That's all I have for you. It's getting late pretty here in the East Coast, Dr. Ara. So you go by Dr. K. I'm sure that not many people will call you Dr. Karamanian because they'll stutter just like I did.
It's okay. And the relationship I think that I've developed with my patients runs deeper than a letter or a name,
than the name. Well, Dr. K, nothing I'm drawing a connection here. Nothing was this by intent, connection with Coach K from Duke or what's going on?
I would not be anywhere close to in arrogance to suggest that I would have any sort of right or position to be able to be mentioned in the same sentence as Coach K.
Let's say that you're the Coach K in focal laser ablation therapy. We can say that. Why not?
Well,
people say you're the.
I'd love to be a part of training a crop of highly skilled men's imaging radiologists in terms of making sure they get good image quality, prep the patients properly, interpret the images properly, recommend the right types of biopsies, have the skills to execute on those. I would love to be a part of that. But for that to happen, it really you need the academics, you need the American College of Radiology, you need the American Board of Radiology. You need urologists. You need all of us to work together to get there. And the women and the men who love women, were able to get a lot of those things to happen with the Mammography Quality Standards Act, the MQSA. And I think it's time for us men to be a little more proactive about our health, and I think, and also it's incumbent upon us as physicians in the areas where we practice to push for these things that we know are good and right.
Well, I love it. Those sound like they're your final words. And Dr. K, where can people find you if they want to reach out?
My website, prostatelasercenter.com. I also do Tulsa, which I believe is complementary to laser, and which is also real-time MRI guided. So the website is prostatelasercenter.com.
Great. Ara, thank you so much for what's impressive to me is that you speak about what you do with such passion that it kind of rubs off in such a positive way. And I love passion, particularly as it relates to a craft. And you are the best, if not one of the best at it. And I really appreciate you being on.
It's really my pleasure.
Talking to our audience
my
today.
father's a retired physician, and he hammered it home in me: take great care of your patients, and all the rest will work out.
Beautiful. Beautiful. Thanks so much for being
on.
on.
It's my pleasure. Thank you.
All right, everyone. Thank you. Oh boy, this was a lot of fun. Certainly over an hour, which is a rarity, but things were going so well and went so well that I didn't want to stop it. It's very important for you to make well-informed decisions, and we are here to help you when you're involved in that shared decision making. So thank you so much for tuning in today and all the times that we post. I really appreciate you as always, and stay well, stay fit. Much love. This is Dr. Gio signing off. Talk to you next time. Thanks for tuning in to this week's episode of the Dr. Gio podcast. You can watch all episodes of this podcast and much more by subscribing to my YouTube channel. If you love what you heard today, you can help by leaving a 5-star review of the podcast on Apple and Spotify, as each review helps us reach more men who are serious about improving their urological health and how to function better with age. And for the latest research and actionable takeaways in the world of men's health and integrative urology, sign up for my newsletter at drgio.com. I'll see you next time.